everyone. Thank you for joining us for this MDA Engage community webinar on gene therapy. Gene therapy has emerged in the recent years as a treatment option for Duchenne muscular dystrophy, and it is important for the neuromuscular disease community to learn more about the current and potential future landscape of treatment options for themselves or a loved one. My name is Michelle Barrios, and I am the Community Education Specialist at MDA. We are thrilled to have you join us today for this important and educational webinar. The webinar today is part of our larger MDA Engage flagship community event series, which focuses on bringing the neuromuscular disease community together around education and social opportunities. Be sure to visit the MDA Engage section on mda.org for updates on upcoming virtual education events. We are recording today's event and will be posting it to the mda.org website for on-demand viewing to ensure that those who were not able to join us live today are able to access this information. Please know that all phone lines have been muted. We will be having a question and answer session towards the end of the webinar. Please be sure to utilize the Q&A window to type in your questions. If you hover over the bottom of your screen, a tray of webinar icons will appear. Click on the Q&A bubble to open the window and enter your question. You do not need to wait until the Q&A session to chat in your questions. As questions come up along the webinar, please feel free to send those in. Before we begin, I would like to say thank you to our speaker, whom you will meet shortly. Let's review the objectives for today's webinar. Participants will listen to a brief overview of gene therapy, review the current state of gene therapy treatments for DMD, learn what is important to know about gene therapy for DMD, and discuss pros and cons of gene therapy in individuals with DMD. I would like to now introduce our speaker, Dr. Abid, and turn the webinar over to her.
Michelle, can you disable the video? I cannot start the video. Okay. Okay. Hi, everyone. I would like to thank MDA for inviting me for this webinar. I am so honored to be here. So before I start my presentation, I would like to share a story of one of my patients. So 7 to 8 years ago, one of my patients who was diagnosed with Duchenne muscular dystrophy, he was 14 years old, and he actually stopped walking at age 13. And one day in the clinic, he asked me, Dr. Abid, when I'm going to walk again? And I want to walk to the stage to get my high school degree. And at that point, I was speechless. I didn't have any answer for him and I also don't want to give him false hope. But since then, there was so much development in the field of Duchenne muscular dystrophy. There were so many drugs in clinical trials, in development. We have some drugs which are approved to use for Duchenne patients. And now I am not hesitant to say that we are not too far away from curing this devastating and life-threatening disease. I don't have any disclosure. And this is our clinic census for muscular dystrophy. So we see more than 40 different types of neuromuscular disorder in our clinic. And the most common disorder we see is muscular dystrophy. And among muscular dystrophy, you can see that 2/3 of our patients have Duchenne muscular dystrophy. So that's the most common neuromuscular disorder we see in our patient, in our clinic. So before I start my presentation on gene therapy, I would like to give you a brief overview about Duchenne muscular dystrophy, its current treatment, So as you all know, that's the most common and severe form of muscular dystrophy, which is inherited and runs in the family as like X-linked recessive disorder. So most of the time, mother is a carrier, but it can be, a patient can have spontaneous mutation in 30% of the time. It causes progressive muscle degeneration and muscle weakness. Incidence is, as I said, is the most common. So 1 in 3,600 male and ranges from 3,500 to 5,000 male. And the prevalence is around 16 per 100,000. And we have like 9,000 to 12,000 patients in USA. So dystrophinopathy is a spectrum of disorder, which is due to deficiency of dystrophin protein. And it ranges from one end, which is a most severe form called Duchenne Muscular Dystrophy, where you have significant weakness and kids cannot walk after a certain age, to the other end, where we have a mild disease when some of patients continue to walk even after 40 years, and that's called Becker muscular dystrophy. And there are some patients who actually lies in between Duchenne and Becker. So they have intermediate type. They're more severe than Becker muscular dystrophy and less severe than Duchenne muscular dystrophy. And they may continue to walk till age 15, 16, or maybe 17. Some patient may have X-linked dilated cardiomyopathy, which means that the patient may develop cardiac symptoms before developing significant weakness. And you can see that also in female carrier, that they may develop cardiomyopathy only. So where is the problem? If you see the muscle, it has multiple kind of fascicles, and each fascicle has multiple muscle fibers. And each muscle fiber has myofibril or myofilaments. So this is the interior of the muscle fiber. You can see we have myofilaments here, which are the contractile, agents or elements in the muscle fiber. And then you can see here multiple different proteins. These are linked to each other. These are the structural proteins that make a cytoskeleton, which actually connect the inside of the muscle fiber to the exterior, which is the extracellular matrix. And what it does is during the muscle contraction, it actually protects the cell membrane to get injuries. And dystrophin is one of the structural protein. And dystrophin protein does not only express in skeletal muscle, but it does express in cardiac muscle. That's why we develop cardiomyopathy. It also expresses in brain. And some patients with Duchenne muscular dystrophy, they can have developmental problems like speech delay. I have few patients who develop autism. So you can see different type of cognitive dysfunction like learning disability, intellectual disability in these patients. It also expresses in smooth muscles. So like GI muscles, patients can have symptoms related to that, like constipation, reflux, gastroparesis. Schwann cells is basically covering of nerves. So some patients may develop factor Schwann cells and they may develop kind of neuropathy. And also in retina and in late stage, you can see some patients may have night blindness. So as I mentioned you, the dystrophin is one of the structure proteins. So it's like a shock absorber for muscles. So it prevents injuries to the cell membrane along with other structure proteins. So if you consider dystrophin as a rope which connects the anchor, which is a cytoskeletal, the skeleton of the muscle fiber to the extracellular matrix, that's how the boat, which is muscle, can function. So what happens if we miss dystrophin? So as I mentioned you, that dystrophin and other structure proteins maintain the integrity of the cell membrane. And if it's absent, one of them is absent, it can cause increased fragility of the cell membrane and the cell membrane become leaky. So what happened when it become leaky, that cause increased influx of or entry of calciums. Calcium actually trigger a cascade of event. It activates the inflammatory pathway and cause increased inflammation in the muscle. And that leads to mitochondrial dysfunction, decreased blood flow to the cell, muscle cells. And then it also cause increased fibrosis and then Also, it affects, cause degeneration in the muscle fibers. So you can see gradually during the contraction, every time we contract our muscle and relax, the membrane get more injuries. So gradually you can see that the degeneration is progressing. And that's what happened to our muscle when we have absent or decreased dystrophin. And if you look the muscle under microscope, this is a normal muscle where you can see the cell size are equal, same color, the nuclei are outside, at the periphery. And if you look the muscle under microscope of a patient with muscular dystrophy, it looks really ugly. You can see that there are different sizes of the cell. It's have different colors. You can have accumulation of fatty tissues. There's fibrosis, there's increased inflammatory cells. So you can see really abnormal looking muscle. So dystrophin gene was first identified in 1986. And then in 1988, we started doing the genetic test for dystrophin gene. It's the largest gene in the body, and it has 79 exons, means 79 puzzle pieces. And it's present in the X chromosome. In Duchenne muscular dystrophy, 90% of the patients have a mutation which actually shift the reading frame, and that's called out of frame mutation. But 10% of the patients may have in frame mutation where the reading frame is intact. So what does it mean? It means that, for example, if we have a genetic code for Duchenne muscular dystrophy, which is not this code, but I'm just giving you an example, the big dog has one red eye. This is a code for, or the recipe for dystrophin protein. One is transcribed, and it transcribed as the whole sentence, then you will make the normal dystrophin protein. But if you're missing few letters, for example, if you miss DO from this sentence, once it's transcribed, you can see that you cannot read after big, you cannot read, it doesn't make sense. So here the reading frame stops, and then there is no production of dystrophin. On the other hand, if we miss a whole, like 3 letters, like BIG, and once that transcribed, you can see that transcription, the sentence, it still makes some sense. Although it's not the full sentence, but it's short, but makes sense. And you can make some dystrophin. So that is in-frame mutation. And the first one was out-of-frame mutation, which you see more in Duchenne muscular dystrophy. And in-frame mutation, you will see more in Becker muscular dystrophy. So that's how we can predict, like after the genetic testing, that patients who are going to develop Duchenne versus Becker. And we have seen more than 7,000 mutations in dystrophin gene, which can cause dystrophinopathies. The most common mutation is deletion, which accounts for 60 to 70% of the patient. Then 5% may have duplication. And then 25 to 35% have like a point mutation, very tiny changes in the nucleotide. So to explain the out of frame in an easier way, so if this patient is missing exon, as I said, that 79 exons looks like a puzzle pieces, and they fit with each other. So if a patient has, loss of 48 to 50, you can see that the shape of 47 and the shape of 51, it does not fit together. And that's actually created a premature stop codon. And that's why dystrophin cannot be made. And as I mentioned you, that dystrophin is a rope which connects the cytoskeleton to the extracellular matrix. This rope is going to be detached, and no more anchor is going to be connected to the cell membrane. And that's why the boat muscle, which is not going to function. While in the in-frame mutation, if patient is missing 48 to 51, you can see the 47 is going to fit to 52. Although this is going to be a shorter dystrophin gene, but it still can make some dystrophin, and you can see that the anchor is still connected and the muscle is, or boat is going to function. This is just a natural history of Duchenne patients, like when they start having symptoms, how they progress. So I would say 28% of the patient may have symptoms before 18 months. They may present with delayed walking, toe walking. Between 18 months to 3 years, I would say 30% of the patient present with motor delays. They have difficulty with running, jumping. And after 3 years, more 42% present with symptoms. So like they may have at that time, like difficulty with walking, some muscle weakness, difficulty getting up from the floor, muscle cramps, easy fatigability. And when they are 5 years old, you can see their gait looks abnormal, which is like a waddling gait. By 7 years, they may have significant difficulty with motor skills, and sometimes they need wheelchair or scooter for long distance. By 13 years, most of the patients stop walking. And then once they stopped walking, they started developing other complication, which is related to breathing, orthopedic complication, like due to progressive muscle weakness, they develop contractures, scoliosis, foot deformities, and cardiac complication also start around that time. And by 20 years, most of the patients need non-invasive ventilation, especially at nighttime, and they have significant upper body strength, loss of upper body strength. And by 30 years, patients may die because of the respiratory and cardiac complications. The age is now, like, survival is actually getting better since we have so many treatment and standard of care for Duchenne muscular dystrophy. So we do have patients surviving up to like 40s. So I will briefly touch the current and emerging therapies, especially the current what we are doing, how we come up with the target therapy, how we target therapies in Duchenne muscular dystrophy. So as I mentioned with the pathophysiology, that when the cell membrane is leaky, it causes increased influx of calcium. So we target if we can use something which inhibits calcium influx by using some calcium channel inhibitors or some other drugs which improve calcium hemostasis. Then there is increased activation of inflammatory pathways. So we use something to prevent inflammation or fibrosis, like steroids is one of them. There are some clinical trials going on with antifibrotic agents. The blood flow is affected. There are some medication which increase or cause vasodilatations, which increase the blood flow. Mitochondrial function is also affected. So there are some mitochondrial enhancers we use, like probably you heard about CoQ10. There is a medication called edavenone. There are trials going on with these medication also, and there are cardiac medication we use because we know the heart muscles are also involved. They have tried stem cell transplant for cardiac, cardiomyopathy, but it didn't show much promising result. The other two targets are one to restore dystrophin or may replace the defect. So by doing certain different technique, we can do that. So one is exon skipping. I'm going to talk about a little bit about that. Then gene therapy, that's the main topic. CRISPR, I will touch base with that too. And stop codon it's used for certain type of mutation, like nonsense mutations, which covers 20% of the patient. And then other technique is to increase the muscle size by improving the muscle growth. And there are certain drugs in pipeline which are actually showing improvement in muscle growth. One is the myostatin inhibitors. Polystatin is also one of the myostatin inhibitor, and it's increased muscle growth. So if you increase the size of the muscle, the function is going to be better too. Androgen is also hormone which increase muscle growth. Utropin is actually is similar to dystrophin, which is present in early life. So if we replace dystrophin by utropin, it's going to have the same function, and it will protect further progression of disease. And there are trials going on with that too. And stem cell has been tried also for muscle growth and protection, which didn't have much, good outcome in the clinical trial. So once we diagnose patients with muscular dystrophy, we do follow a standard of care, which is a guideline actually published in Lancet in 2018. So how we diagnose, there are like 11 actually areas we have to address. And the first one is how to diagnose these patients. And then nowadays we are using genetic tests, which is pretty sensitive, and more than 95% of the patients can be diagnosed by just using genetic tests. So we don't have to do muscle biopsy in these patients now. And then we have some approved treatments which we offer our patients, like steroid, exon skipping treatment. These patients, that it causes progressive muscle weakness, so they develop contractures, they have foot deformity. So they need to see physical medicine rehab doctor. They need to see therapists also, like physical occupational therapists. They may have problem with related to steroid, delayed puberty or short stature. So they need to see endocrine also. GI, because as I mentioned the smooth muscle is affected. Respiratory and cardiac management, because progressively they become when they get more weakness, they actually develop respiratory complications. They develop cardiomyopathy, so they have to see all these specialists. Bone health, because of deformities and scoliosis, they need to see orthopedic. And bone health, because the patients use chronic steroid, and then also because of the decreased mobility, they may have decreased bone mineral density, so they need to get some help in that area also. And Duchenne patient, as we know that they are actually surviving long, and we have having come across with some mood issues, some other psychological problems, so they need sometimes psychological help. And again, because they are more adults we are seeing with Duchenne, so they need to address areas like their employment, their education, so that needs to be addressed also. So these are the 11 areas which we have to address when we see patients with Duchenne muscular dystrophy, and we try to get them in our multidisciplinary clinic where they can see at least as many of the specialists in one time. So current therapies, as I mentioned there are 2 steroids available. The deflazacort is the only one which is approved by FDA, and prednisone has been is available since a long time, and we have been using that. Is still using as a first line because of the cost. There are little difference in the efficacy. It shows that deflazacort is a little better in efficacy than prednisone. That patient may continue to walk 1 to 2 years on deflazacort as compared to prednisone. There are some slight difference in the side effect profile also. And the exon skipping, if we do exon skipping for all patients, then we can cover from like 75% to 80% of the patient. But we have 3 treatments available. Exon D51, which is approved in 2016 September, that covers 13% of our patient. Then we have VYONDYS, which was approved in 2019 February, which covers 8% of the patient. And then recently in February this year, we have exon skipping 45 treatment available, which covers. So total coverage we have right now is 30% of our patient. And there are many in pipeline, which hopefully they're gonna be approved soon. So what exon skipping means. So as I mentioned before, that patient who have out of frame mutation, so this one missing 48 to 50, and this is not gonna fit to 51, so it causes stop codon, premature stop codon. So if we skip 51, by using ASO, which is an antisense oligonucleotide, these are synthetic RNA pieces which attach to the specific exon which we are targeting. So if we skip 50, if that AON is going to attach to 51, then it can be skipped during the reading. So you can see that we can resume the reading frame and we can still make some dystrophin. So if you can see here that the patient who lost dystrophin with this treatment can still make some dystrophin, so the bone or the muscle can function. This is another way to describe, this is a healthy patient who have normal, genetic component for protein, dystrophin protein, and they can make normal dystrophin. And this is a patient who have, missing exon 49 to 50. And you can see that 48 cannot fit to 51. It creates a premature stop codon, and we cannot make any dystrophin. If we use exon skipping treatment at a percent, which is the 51 skipping treatment, if we skip 51, you can see that his frame is going to be resumed, although it's short, and you can make some dystrophin protein. So they did some, before the drug came out, there was some functional data which monitored by 6-minute walk test. And you can see here the patient who were treated with exon skipping treatment 51, they actually walk better than the patients who were not initially treated, but started, exon D51 later on. There was a difference of 75 meter in their 6-minute walk test after 144 weeks. And then they also measure dystrophin expression in the muscle biopsy at 12 weeks and 24 weeks and 48 weeks. And then you can see that gradually the dystrophin staining shows improvement in dystrophin level. And you can see in Western blot, which is a quantitative evaluation, you can see at 48 weeks is much better than pre-treatment. This is a healthy patient dystrophin level. Okay, so now let's talk about gene therapy. So gene therapy is replacing faulty gene by using viral vector. And this is to just give you illustration about how we make protein in our body. So we know that every cells in our body have DNA. And so DNA carries information or recipe for the protein. And once our body needs protein, that DNA actually transcribes that information to another molecule called messenger RNA. And messenger RNA carries the recipe to the cytoplasm. There is another molecule called ribosome, read that information and tell another molecule, which is a translation RNA, to bring the ingredient of that recipe. And translation RNA bring all the ingredients in the form of amino acid will lay down and then make the protein. So what we need for gene therapy? So there are main 3 essential components. One is a vector, and in gene therapy for Duchenne Muscular Dystrophy, we utilize adeno-associated virus, which are non-pathogenic, does not cause any disease in human. And it targets muscle fibers. So it has an affinity to target muscle fibers only. That carries the gene and enter the muscle fiber and protect the gene while it's transferring throughout the body. The second component is promoter, and promoter is which actually tells the cell when to turn on or turn off transgene. And promoter also, there are some specific promoter which are selective, which actually are more specific for certain type of tissues like muscle fibers, like a skeletal muscle, cardiac muscle, or diaphragm. And then the third component is transgene. So transgene is, as I said, microdystrophin. And how we come up with this concept of microdystrophin is because the virus it cannot accommodate the whole dystrophin gene because it's the largest gene in our body, and there is no virus which can accommodate the whole gene. So the concept of microdystrophin came from observing patient or studying patient who have a milder disease like Becker muscular dystrophy, and when they sequenced their gene, they found that although they are missing like big portion of dystrophin gene, they still are ambulatory at age 60. So they actually got that concept and make this microdystrophin gene, which can be accommodated in the viral vector. And that's how the microdystrophin was engineered. So not all portion of the dystrophin gene is critical for muscle function. There are some portion, even if you are missing, the muscle still can function. So that's how we created microdystrophin. It does not have all exons, it's 79 exons. It doesn't have that. But it has a critical portion of the gene, which is important and critical for muscle function. So the transgene has promoter, which determines where and when gene is turned on and off. And then we have a part of the gene here. And then we have another stop sequence at the end, which marks the end of the coding region. So that's the transgene. So how we deliver, gene into our body. So we use the viral vector, we inject in our body, IV, and then it enters in our system and then target the muscle fiber. And once it enters into the muscle fiber, it waits to enter into nucleus. And then in nucleus, the transgene is released from vector, and it does not incorporate with the patient genome. It makes a small circle, and it's called episome, and then start transcribing. And then you will start making dystrophin protein. Although it's going to be shorter dystrophin protein, but it will actually improve the muscle function. Gene therapy, as we know that we are using viral vector. So if you're introducing any foreign object in our body has an innate immunity, which is a non-specific immunity we carry, and we turn it on as soon as we see any foreign object. So initially when you introduce gene therapy, there may be some patients have some symptoms like vomiting, headache, fever, which could be due to the innate immunity, which is not specific to that virus. But gradually, our bodies start developing acquired immunity towards that virus. And that's why gene therapy cannot be repeated, because if we repeat the gene therapy, we already have exposure and we have already make antibodies, they're gonna be a severe reaction. But even in the body, the virus is actually gradually, the concentration may decline because of the acquired immunity. And we don't know how long the virus is gonna stay in our body. Like in animal model, they found that in mouse model, that can last for till their life. In dogs model, they found that it can last up to 7 to 8 years. We don't know in human that how long this is gonna last, for many years, or we have to repeat or give a booster. We don't know yet. This question is not answered yet. We can monitor multiple clinical endpoints at different stages of Duchenne muscular dystrophy disease progression. So as we know that in early stage, like patients who are less than 4 years old, they have some mild symptoms like delayed walking, some difficulty with motor skills, running, hopping, jumping, getting up from the floor. At that time, we can monitor motor function by utilizing belly motor developmental measure. And then we can also do North Star ambulatory assessment and the time function test. Time function test utilized time to rise, or time to take 3 steps, or time to run 10 meters. They don't have any problems of lung function, so we don't need to do any monitoring at that age. It's difficult to do muscle strength testing at this age because lack of cooperation. And then when they turn 5 to 7 years, they have some modest functional decline. They will have more difficulty getting up from the floor. They lost, climbing, like stair climbing. So at that point, again, we can monitor motor functions by North Star ambulatory assessment. TFT is a time function test, and also 6-minute walk test. And then by 8 to 12 years, they have significant weakness, and some of them may have lost ambulation. At that point, if they're ambulatory, we can do 100-meter walk test, and also North Star ambulatory assessment, time function test, 6-minute walk test. And there's another quantitative measurements of muscle testing, which we use dynamometer, which actually can reflect any tiny changes in muscle strength. In early teens, when early non-ambulatory stage, we cannot perform time function test or North Star ambulatory assessment. So at that point, we can use more like a upper body strength, assessment, which we call performance of upper limb by utilizing Brooks scale or revised upper limb modules. At that time, patients started having decline in their lung function. So PFT we started using to monitor, and also the quantitative muscle testing, or by utilizing dynamometer. We don't do that in our clinic. I usually do more like a bedside muscle testing. We're utilizing MRC, medical council research testing, which is just check every muscle strength. In late, like when they lost ambulation, there's another scale which has been used, which called EK, which is Egan Classification Scale. And that actually monitor patients that how they move their trunk, transfer from wheelchair to bed, their well-being. That's also used for research. We don't do it in our clinic. And then again, upper limb strength and PFTs and QMT. And late stage also we utilize these tests to monitor their disease progression. So when we do gene therapy trial, we need to follow what we are looking. So usually we look for safety, tolerability, that patients don't develop any side effects, how much dose they are needing to have a good result. And then secondary outcome to measure dystrophin level, in this case, microdystrophin protein expression, and then some functional assessment like North Star ambulatory assessment, and then time function test, 6-minute walk test, and pulmonary function test also. There are some studies looking into also cardiac function. So North Star ambulatory assessment is a validated scale, and it's been used for most of the studies for Duchenne Muscular Dystrophy. And it has 17 domains, and you can see most difficult to least difficult, which patients lose late. And we give 2 points if they can perform that skill, and 1 point if they perform with difficulty, and 0 when they're unable to perform. So total is like 34 points they can get. And it's important to know that North Star ambulatory assessment, if you look at the natural history, that patient may continue to gain points till a certain age. So in the natural history of, Duchenne natural history, we found that patients can gain 3 points per year till age 6.3 years. But after 6.3 years, they start declining 3 points per year. So we have to be very careful. We are monitoring the scale in the research that how much they are gaining and what age the patients are. So DMD gene therapy trial, there are 3 companies who are doing gene therapy trials, Sarepta, Pfizer, and Solid. In Sarepta, they have 3 studies. The phase 1, which was SRP 101, they enrolled 4 patients, ages 4 to 7 years. And the primary endpoint was safety and tolerability. And then a secondary endpoint was microdystrophin expression, which shows a very positive result of more than 90% expression of microdystrophin in these patients. And even the time function test and the NSAA score shows greater than 6-point improvement over 12 months. So it was a very promising result we saw with the phase 1 trial. The second trial, which was phase 2, which has been going on, they enrolled 41 patients, and recently they released the results of 20 patients, and all the patients were 4 to 7 years old. And that actually shows not as remarkable result as the phase 1 trial. Then they are also working on another trial, which is SRP 103, and same age group. They're using a different vector, not the same one which they use for phase 1 and phase 2 trial. And then Pfizer study, they enrolled 12 patients between 5 to 12 years, and they gave 6 patients high dose gene therapy, and then 6 patients were placebo. And after 12 months, the placebo got the low dose gene therapy. There were 2 patients, they have significant adverse reaction. One had the kidney injury and hospitalized, and the other one have persistent vomiting and hospitalized also. So they're not enrolling more patients, but they are following these patients. And because of the increased viral load in Pfizer study, they are having more, probably the reason they have more side effects. So they're using the more potent immunosuppressive agent, which is Solaris, which is a monoclonal antibody infusions. And then they are just started, not started now, but last year, phase 2 trial, which enrolling, probably enroll 99 patients, and age group is 4 to 7, same as like Sarepta. And they are recruiting. Last I heard that some of the patients are still waiting for this trial to be enrolled. The SOLID trial, which enrolled 9 patients, 3 were high dose, 3 were low dose, 3 were placebo. And again, there are 2 patients who have a severe adverse reaction. One was developed hepatotoxicity, and the other one low platelet count. And that's why they held the study, not enrolling more patients, but they are following these patients, and they are showing that none of other patients develop any adverse reaction, severe adverse reaction, and they actually showing improvement in their function, the time function test and the North Star ambulatory assessment, and the expression of dystrophin also showing some positive result. So this is a summary of gene therapy. The safety, if you look at SRP, which is Farida 1 or 2 study, the 82% of the patient had mild to moderate adverse effect, and most of the symptom was vomiting. And 3 of patients have sudden breakdown of muscle, which is rhabdomyolysis, and 1 have elevated liver enzyme, but they were treated and they were recovered completely. And in Pfizer study, 4 out of 6 patients developed nausea, vomiting. Actually, 1 developed severe vomiting and was hospitalized, and 1 patient developed severe kidney injury, and they later improved. And in SOLID, they have 2 significant severe adverse reaction. One was the hepatotoxicity, and the other one is low platelet. If you look at the microdystrophin expression, Sarepta used Western blot, and it shows that 28.1% improvement as compared to normal after 12 weeks. Pfizer used different scale, which is spectrometry, and that shows 23% improvement in mean expression of microdystrophin in low dose and 29% improvement in high dose. And in SOLID study, they have 1 patient actually improved 30 to 50% in mean dystrophin expression, but overall it's like 10 to 50% in 90 days, and all 3 doses. And if you look at the functional assessments, as I mentioned you that SRP 1 or 2 did not show comparable result to SRP 101. So their change in NSA score was 1.7 as compared to 0.9 in placebo. In the 101 study, it was 6.4. So that's much different. And the dystrophin expression is also low, and they think that there is a problem in the randomization. The patients who are 4 to 5 years old, they have improvement up to 4.5, but patients who are 6 to 7 years old, we have only 1.7. So you can see that patients who are less than 6, they continue to improve in their NSA score, but after 6.3 years or 7, they start declining. In Pfizer study, you can see the 2 patients who are 7 and 8, they actually have an increase in NSA score of 4.5 after 12 months, which is kind of, I would say, meaningful because of the age. And in SOLID, these patients have been monitored, and they are showing improvement in 6-minute walk test, NSA score, and they're also measuring forced vital capacity because their patient population was from 4 to 17 years. So they included both ambulatory and non-ambulatory patients. They also monitor CK level, and all studies, they monitor CK level, and it shows decline over time. And you can see with the gene therapy, these are the risk of having adverse reactions. These are the adverse reactions we expect. It's because of the, when we inject virus, the immune system get activated, and most of the side effects are related to immune reaction. So liver, GI, hematological, like especially low platelets. Then 1 patient shows a kidney injury. Even cardiac toxicity could be possible, and some patients may show elevated troponin level. There are some possibility of that, so it could be related to steroid-associated events, or maybe because of other reason like sepsis. I will touch base with gene editing, which is called CRISPR-Cas9 technology. Gene editing is that basically you are editing DNA of the patient's, like patient's DNA. And you fix that, and then when the DNA transcribe, they can make normal protein. So Cas9 is using this technique using endonucleases. These are enzymes which cleave, exon a certain area, and it's actually, using viral vector to transfer that. This technique can be done in different ways. So there are like 3 types of editing you can do. One is like, if, for example, a patient who lack exon 44. So you can see that frame is gonna be changed, and it's gonna cause a premature stop codon. So what we can do is maybe we can skip 45, so this frame can be resumed, and you can make some dystrophin, like shortened dystrophin. Or we can edit 45 so it can fit into 43. So you can see there are some changes there, and now 44 can fit to 45, and you can make normal, not normal, but shortened dystrophin. Or maybe we can replace 44, and that way you can resume a normal dystrophin gene sequence, and you can make normal dystrophin. And this is actually in very early stage of development, like, animal models studies being done. And it looks very promising in a way that in animal model, they have seen the expression of dystrophin maybe as high as like 60%. So it's very promising, but we will see what the human trial shows. With that, the conclusion of my talk is, I mentioned that Emflaza is the only approved steroid treatment for all DMD patients. Now it's approved for ages 2 above. And we have exon skipping treatment utilizing PMOs. PMOs are the synthetic RNA, which doesn't have that much penetration into the cell. So they are now working on utilizing PPMO, which have better penetration. And then it has shown that the expression of dystrophin can be as high as 6 to 10%. With PMO, the expression of dystrophin is low, like 1%. That's why patients may not show that much clinical improvement. So with PPMO, we're expecting that it's going to change the outcome, and it will be much better. And even if we are using PMO and it's making very low dystrophin expression, it still is going to delay the disease progression. And we are seeing that the patients who are getting exon skipping treatment, they are showing delay in progression of their disease. And we know that the AAV vectors are non-integrating, non-pathogenic, and it allows target gene delivery. But we still need more work to improve the vector productivity, stability, durability of response, and safety. And there's so many different target therapies in pipeline. And we are working on newborn screen because we want to diagnose these patients before they develop significant muscle damage and fibrosis and scarring, so they will have better response to treatment. And with that, I would like to thank again, and I will be happy to take any questions.
Thank you so much, Dr. Abid. I will stop your sharing and go back to mine. We already have some questions that have come in. The first question that has come in is, if calcium is a loss of nutrition, can calcium pills or milk give back the calcium needed?
It's not the calcium level which is affected, it's just the entry of calcium into the cell, which is harmful for the cell. So we are utilizing drugs which can inhibit calcium, entering into the cells. And so there are some target therapies which we are working, like ranodine receptor inhibitors, which can help to, prevent that influx and help to prevent, inflammatory cascade. So dietary calcium is not going to have any effect, but it's good to have dietary calcium because of the bone health, muscle health, we need that, but it's not going to be a target therapy for Duchenne muscular dystrophy.
Thank you. Like I mentioned at the beginning of the webinar, if you have any questions, feel free to chat them in, or you can also use the Q&A at the bottom of the screen to chat in your question. Another one that has come in, and this might be specific to this patient. So if it is too specific and you would need more information, feel free to say that. But this one says, what does exon intron 18 DNA change C2281 underscore 2285, and this is in the chat if you want to look at it as well. Deletion mean on my child's genetic report? How does it relate to the 79 puzzle pieces?
Okay, so there is a possibility, because I have to check, is it an out of frame mutation which disrupt the reading frame, versus it's an in frame mutation, because that's very important. So I have to go, check that exactly with using the gene, check like a, it's called a checker, where we put all the deletions and we see if it's out of frame versus in frame. So if it's out of frame, we can say that 90% of the chance that the child is going to develop Duchenne muscular dystrophy and it's going to be more kind of severe disease. But if it's in frame, that the child may have milder disease, maybe like Becker versus intermediate type. So it's very important to know if it's out of frame versus in frame mutation.
Thank you. Another question that has come in says, can this therapy help with the intermediate kind of muscular dystrophy, so gene-targeted therapies?
Definitely, because as I said, this is kind of, you are providing microdystrophin, that the patient has significant loss of dystrophin protein. That's why they develop, the intermediate type and have significant weakness. So if you provide some microdystrophin, that will help to improve the muscle strength and may delay the progression of disease, or maybe have a very mild disease if we treat it earlier in this disease stage.
Thank you. Another question, if a patient has already tried one form of treatment, whether it's something that has been approved previously or in a clinical trial, will this affect their possibility of receiving treatment, gene therapy treatments in the future?
So as I mentioned you in my slide, there are different targets therapy, which is targeting different areas. If you remember the pathophysiology. So if you're using like a steroid, we are combining that with the exon skipping treatment. And if their patients are using exon skipping treatment, we can still use gene therapy in these patients. The only problem is that because right now the exon skipping treatment, we are not using viral vector, we are using drug. But now I would say research and clinical trial going on, which utilizing viral vector for exon skipping. So if you already use a viral vector, which is similar to the one that they are using for gene therapy, that's going to be a problem. So that's why it's important to know if they already had any kind of gene therapy before, or if there is a similar vector they're using. But if it's different, yeah, there's no problem. You can use gene therapy if you're tried on other treatments.
Another question that has come is, what is the outlook from gene therapy for the ages of 3 and 12 years?
So so Sarepta trial utilizing 4 to 7. Pfizer used 5 to 12 years, but their phase 2 is like only 4 to 7. Only solid, they actually have patients from 4 to 17, 5 to 17. So they are trying both ambulatory and non-ambulatory patients. But the problem is that we don't have any data on the patients who are older, above 7 years. So we are still waiting to see more data about patients of older age and see how they are going to make, how this therapy is going to help them and what outcome they are going to have. So we still need more data on that.
Okay. What about patients with exon duplication? Will they benefit from gene therapy, or at the moment just steroid treatment?
So duplication is also another target for exon skipping. We don't have yet, but it can be. And again, by gene therapy, that's going to be also a possible treatment. There are other treatments, as I said, in pipeline, which are targeting different areas like myostatin inhibitors. There's treatment like CRISPR, which probably in future going to make much difference. So yeah, there are other treatment options. Even exon skipping can be possible for duplications.
Another question that has come in is, are other larger viral vectors being investigated which will be able to contain and transport the full dystrophin gene?
At this point, because when we use viral vector, we have to make sure that they are safe for human. It's not disease causing and it's not cause any severe immune reaction. So right now we have adeno-associated virus only, and that actually cannot accommodate the whole dystrophin gene. There are other genetic conditions like SMA, which are utilizing the whole gene because it's smaller and it can fit into that virus. So at this point we don't, but maybe in future they will find more, or maybe produce some viral vector which can accommodate the whole gene.
If someone is interested in having their child join a clinical trial, what would your best recommendation be for that?
So when we see patients, we actually talk to them about all the clinical trials which are open for patients, and we actually give all the information to them. But parents need to contact the centers because they can evaluate them and they can have to answer all their questions. So we provide all the information. And I would suggest the best way to look into the clinical trials is go to the clinicaltrials.gov, and they actually post all the trials which are going on in the whole world, I would say. And that you can keep an eye. If you have seen anything which you feel like interested, just call us and let us know, and we can discuss with you about, is it good for your child to be enrolled or how you can be enrolled, and we will provide all the information.
I would also like to add that MDA has a clinical trial finder tool on mda.org, which makes it easier to navigate through clinicaltrials.gov. Sometimes the website can be a little difficult to navigate, and the clinical trial finder tool on MDA allows you to put in the diagnosis and everything just pops up for you.
Okay. Yeah, good information.
Another question that has come in is there any benefit to gene therapy or other therapies for someone who is 24 years old?
If they have not received any treatment and they have significant weakness, I would say that it's going to be difficult to reverse the process with the current gene therapy, what we have. Gene therapy, as I said, is microdystrophin, not whole dystrophin. We actually converting patients with severe disease to milder disease. So once we already developed a disease, you may have delay progression maybe, but it will not reverse the symptoms. So if you are non-ambulatory, I'm not going to give you false hope that, oh, you're going to start walking again with the current gene therapy, what we have. But maybe in future, there are going to be some technique like, which can reverse that process. But at this point, less likely, but it's going to be hope that you will not progress as fast as you will with the natural history.
Thank you. I don't see any more questions in the chat or Q&A. If anybody has any last questions to ask, we still have about 3 minutes left in the webinar. So if you have a question, please chat it in or add it to the Q&A box. I'll give it a second or so. And if nobody has any questions, then I can conclude the webinar. One has come in. If you have any questions on today's webinar, they asked for your contact information. I know you're a very busy doctor, so I will not ask. But if you do have any questions on the webinar or questions that you've had today, send them to mdaengage@mdausa.org or contact our resource center, and we will get you the information that you may need, whether you are in Texas, like Dr. Abid, or anywhere else around the country. I think That is all that's come in. Let me share my screen so that I can conclude the webinar. I would like to thank our guest presenter today, Dr. Abid. We sincerely appreciate your time and expertise and everything you do for the neuromuscular community. So thank you very much. Do you have any last words?
Thank you for having me. I really enjoyed. I hope if they have any questions, they can send me also through MDA if they want. And I'm in Texas, Houston, so.
Yes, absolutely. If you have any questions, I can be the point of the middle contact between our audience and Dr. Abid. We would love to hear your comments about this webinar. If you have a smartphone, open your camera and point it at the QR code on the screen. A web page will pop up with a short survey on today's webinar. If you do not have a smartphone, once the webinar is over, a screen will pop up with the survey as well. Like I said before, if you have any questions about this webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow back up with you. If you are new to MDA through this program and are diagnosed with one of our over 43 diseases under MDA's umbrella, or are a loved one of someone who is diagnosed, we encourage you to stay engaged with MDA. You can do this by visiting mda.org/join and completing a short form. This will allow you to keep up to date on latest information and education to help keep families informed in the neuromuscular community. This concludes today's MDA Engage webinar, Gene Therapy and Duchenne Muscular Dystrophy.